So again, thank you so much for coming. Great to see folks. Without further ado, we're going to launch into our presentation today. Torrie Fields is known to many of us here in Hawaii. We are very grateful for her ongoing engagement and commitment to our community in Hawaii on so many levels. But today she's going to be talking about data, and she will tell you more. But just as a quick bio, she is the Chief Executive Officer at TFA Analytics and a Senior Advisor to the Coalition to Transform Advanced Care, commonly known as C-TAC. She has more than 20 years of experience in population health, value-based contracting, and health services research, and specializes in implementing care and payment models that support people with serious illness. Torrie is an actuary and a health economist with a master's in public health from Oregon Health and Science University and has degrees in sociology and communication theory from the University of California at San Diego. Torrie, welcome.
Oh, thank you so much for having me today. It's great to see so many familiar faces here. So, and thank you, Jeanette, for asking me to come and speak about some updates related to the Advanced Care Transformation Index. Some of you I have seen before, and I think we've even talked about the data related to the ACT Index before, but I'm really excited to share a little bit more detail and some of the updates about measures that really matter to the people with serious illness and what impact COVID might have had on these measures. I was debating whether or not, Jeanette, to share in my bio that, the thing that I love the most about my time in Hawaii actually comes from before me working in healthcare. I am an avid surfer and spent a lot of time on the North Shore of Oahu and getting to know the Hawaiian people since I was very small. And my mom was actually raised in Hawaii, and so it's really exciting to be part of the transformation of healthcare in the state with all of you. As Jeanette said, my organization works very closely with the Coalition to Transform Advanced Care, and C-TAC is a federal advocacy organization that has a primary focus on improving the quality of life for people with serious illness and for their caregivers. And C-TAC is comprised of more than 200 member organizations, of which Kokua is one. And C-TAC has, while it's really centered inside of Washington, D.C. to be a federal advocacy organization, they really depend on the experience and the stories and the transformation and change that happens at the local and state levels in order to be better advocates on behalf of people across the country. And so one of the ways that we do that is through data and collecting the right data so that we can identify opportunities and challenges when it comes to caring for people with serious illness. And so my team has been updating and maintaining the ACT Index report, this Advanced Care Transformation Index, for the past several years. And so I'm going to just give a little bit of a background related to the ACT Index, and then we will dive into some of the Hawaii specific updates that I'm really excited to hear from you, get your feedback, and have a discussion about what we're seeing as trends. So in terms of the agenda, I'll provide a little bit of an overview of the Advanced Care Transformation Index that includes, data sources and where this information comes from, the goals and target audience for the index, what we have been doing to update this report, and the impact of the pandemic and of health equity on these measures, and then we'll start diving into some of the data more specifically. I promise, if you are not a data geek like me, I will make this fun for you. I promise, promise. So otherwise you can get your money back at the end of this. As a proud public healther, I'm very excited to say that CMS has really started to align around some of the goals that we have at the Coalition to Transform Advanced Care. And so I wanted to just set the stage by quickly walking through the CMS Centers for Medicare and Medicaid Services Health Equity Framework. And the Health Equity Framework was implemented starting in 2022. And it has a big, long plan associated with it that has 5 main priorities. And these are priorities that, while they are called health equity priorities, a lot of them have to do with collecting the right data. So the first priority in the health equity framework is expanding data collection and reporting and the analysis of standardized data. A lot of the time, people don't collect standardized data about the seriously ill or serious illness population, and we know even less about people and their lived experiences outside of the electronic medical record or outside of healthcare claims. And so CMS has really taken up a major priority to change this and to start collecting the information that people need in order to transform care. The second priority of the framework is to assess the causes of disparity within healthcare programs overall, and then to identify opportunities to close gaps. And as you see, the third priority is really around when you identify gaps, you need to build capacity. So building capacity of healthcare organizations and of the healthcare workforce to actually be able to use the data that are collected to reduce healthcare disparities. And I think this is something that is really exciting when you're starting to think about transforming care or changing healthcare delivery to make it more equitable and more accessible, especially for people with serious illness. The fourth priority is around advancing language access, health literacy, and culturally tailored services, which I don't really need to tell you on this presentation how important and necessary that is to make sure that the care that people receive is culturally congruent and really aligned with what people need, what they expect, and how they experience life. We all might think that healthcare is our main priority, but for most people, living is their main priority, where healthcare is somewhere ranked a little lower. So in terms of thinking about the fifth priority, the goal is to be able to increase accessibility of healthcare services and to expand coverage for people who really need it. And so this is really the lens or the framework by which we want to take forward the new version of the Advanced Care Transformation Index and how we want to look at these data. The goals for the ACT Index are really to provide a set of publicly available measures that can be used by the public, by healthcare providers, and by policymakers to make data-informed decisions and about what needs to change, what barriers and opportunities there are for people with serious illness, and to actually track progress over time. How well are we doing, and do our interventions work? So these different objectives outlined are really to support organizations like Kokua to prioritize opportunities for improvement, to start to build into your strategic plans, goals, and measures and to determine effectiveness of the interventions that you're really trying to undertake. The ACT Index also can identify best practices and help to identify areas where everybody in the healthcare landscape, including patients and their caregivers, are really aligned. And that can help foster communication and collaboration across a lot of different people. There's a major why behind the index, and that is because the US population is aging rapidly, and we have more than 10,000 people becoming Medicare eligible every day. So we have this baby boomer population that is aging into Medicare. We also know that by 2030, not far away, that the number of Medicare enrollees is expected to double to approximately 80 million people. So now we're actually going to have more people who are aging and more people with serious illness than ever before in our nation's history. And at the same time, CMS has some pretty aggressive goals of their own. They want to make sure that 100% of Medicare beneficiaries and the majority of Medicaid beneficiaries are included in alternative payment models that actually evaluate providers based on their performance rather than fee for service or based on the number of procedures they provide. There are also more and more new care models and new measures that are available for people with serious illness, which gives us an imperative to measure and monitor the quality of serious illness and care experience over time. So this really is coming to a head. And when we're looking at these measures, we want to make sure that the data that we're collecting is being put to work, is being actionable, is able to track success, is able to support advocacy needs and to fill gaps where new measures are needed, and to start to bring best practices across communities so that we can accelerate the speed of change. And so the ACT Index is really targeted toward these specific goals. And how we do that is actually through publicly available data. And so we use a number of different data sources, including CMS data and public health data like America's Health Rankings. We use the Long-Term Services and Support Scorecard, the Agency for Healthcare Research and Quality data, data from the CDC and from BRFIS and Centers for Disease Control, as well as the Dartmouth Atlas trend report to really populate the scorecard that you'll see. And we select these measures to ensure that they are actionable, that they're easily accessible, and that they're aligned with CMS's goals of moving people into value-based care. And in the index that I'll share with you, there are 26 different measures. They are all designed to assess the overall performance for people with serious illness over time. And they are sectioned out by 4 different domains. As a person who most of my work has been in sociology, what we can look at this is as the socio-ecological framework, where you start with yourself and your relationship with another person and how well you are able to communicate on your own behalf, your care goals and your needs. We sort of adjust that out into healthcare providers and community. So the care that people receive and how well we equip caregivers and the community to take care of us. And then we look at larger systemic factors like cost and utilization. One note before I get into the numbers, COVID was really hard for everyone. And COVID also really made a major impact on measurement. So many of the sources in the ACT Index report are annual data sources. And what we found is that there was a lag for many of these data during COVID, and the numbers that they were reporting were really different from the pre-COVID period. And so what we identified were places where COVID plays a role in this story of data collection. We also found that during the COVID pandemic, there were a lot of health equity issues that were uncovered in how we collect data. And so many of the underlying data sources that we use, like America's Health Rankings and Kaiser Family Foundation data, worked to change how they collect their data in order to align with the health equity framework. And so these national objectives, such as striving for health equity and alternative payment, actually shifted some of the measures that the public health data sources were using and how they calculated them so that they actually could incorporate health equity into the way they reported. And so what you might see as part of this is actually a change between the 2020 results that you'll see and the 2023 results that you see. I'm going to talk a little bit about context really quickly because what we used was a timeline comparing 2020 data to 2023 data. And on the federal level, we saw a number of different overall trends that seemed to carry on from state to state. So the major trends that we saw were that food insecurity was a focus of almost every state and nationally. And there was an increase in the number of reported home delivered meals for people over 60 and a decrease in food insecurity for that population. So this is a way to be able to use the ACT Index report to see what interventions work. And on the federal level, you saw that the Biden administration actually identified food insecurity as one of those number one or top 5 strategic goals. And they were able to hold a summit on food insecurity to really tackle this issue. And we saw that play out in the data. In addition to that, there has been a year-over-year increase federally in the uptake of the advanced care planning codes. So more and more providers are billing for advanced care planning across the country. And this is a trend we saw across every state. We also saw that efforts related to 30-day hospital readmissions are starting to pay off, and that now there are overall national reductions in the 30-day hospital readmission rate. This is what I would call a lagging indicator from the Affordable Care Act. The 30-day readmission penalty was the first thing that was implemented as part of the Affordable Care Act. And now it's been 12 years since that was implemented, and we're starting to see some reductions in that area. And I'm excited to see how value-based payment can really accelerate some of these measures as well. There was a decrease in the number of adults over 65 who went without care because of cost, which means that the Affordable Care Act is expanding coverage and starting to make healthcare a little bit more affordable for people. So that's a big win there. We also saw that there was an increase in seniors who had a dedicated healthcare provider. So making sure that people have a primary care provider is really important. And we're starting to see that increase, tick up over time. When you look at Hawaii and you start to lay it out across the 50 states, this is really how we're starting to benchmark states against the federal average. And so this denotes a composite measure across all 26 measures. where, as you'll see, the gold bar is the United States. And on the left-hand side, those are the states that are really leading the way. So Hawaii is really in the middle of the pack when you're thinking about achieving health outcomes for people with serious illness. And we'll dig into a little bit about, how you landed there, and what you could do to really move up or move to the left on this benchmark. So before I share with you the bigger scorecard, I wanted to walk through some of the highlights from your state scorecard. And as I shared, these are in 4 different domains. So the first domain is the communication domain. And what we found were that there was a low incidence of people discharged without instructions. And this may actually identify lapses in communication processes between healthcare providers and their patients. And I know that Jeanette was sharing with me that there have been a lot of efforts in Hawaii to actually make sure that people are being discharged from the hospital with instructions or with follow-up plans. And what we're seeing is that there hasn't been a lot of movement there related to these efforts quite yet. And sometimes this can happen because of high patient volumes or staff shortages or systemic issues within hospital discharge protocols. So this might be something to continue on with in terms of, intervening and starting to help connect the transitions of care between hospital and home when people are admitted. In the caregiving and community domain, we identified that there was a decrease in the number of adults over 60 reporting food insecurity. And this was a decrease by 18%. So what that means is that you're actually getting more and more successful in being able to provide interventions for people to access nutritious food, which does enhance quality of life. So, if you're looking at this measure, this is something that I know the state has been working on in terms of making sure that there is access to healthy food for people who are food insecure. And we're starting to see that pay off already. We also saw a major increase in the number of home delivered meals for people over 60, who also were documented as having independent living difficulties. And that increase in home delivered meals was by 46%, which really does indicate that how much you are focused on this measure. So being able to help people and support them be independent in their homes and to support them while they have health challenges with things like healthy meals was something that I think is a major win for the state. However, we did see a major decrease in the rate of volunteerism across the state. And this decreased by about 10%, which what we saw across the board federally is that this bounce back from COVID really impacted volunteering. We saw that a lot of people could not volunteer during the pandemic. And so these rates dropped drastically during that time. And it's so important to be engaged in your community and to be able to actually foster more volunteer efforts. And so you're not alone in this challenge, but there was a decrease in volunteerism in the state from 2020 to 2023 that we actually, you might want to think about how you center some efforts around that in helping people engage better with their community. In the care domain, this one is a challenge. We saw a major gap in workforce capacity in the state. And this was most pronounced in the decrease in the number of home health care workers and their availability for people over 75. And that's really sort of what the measure is. But if you think about home health care workers and the healthcare shortage overall, we saw a decrease by 80% in this measure. And so this could be a potential crisis in the availability of home health care services for the elderly population. So as I shared before, there are a lot more people turning 65 every day. And we have a lot of interest from the healthcare community to shift services into the home. We can't do that without people who are able to provide services or to aid others in the home. And this could really limit the capacity of home delivered services, and could also impact the quality of care that people are receiving at home. This also rolls downhill to the burden on the caregiver, where if a caregiver does not have that support of a home health aide as part of their care plan, then they are likely to really burn out much faster, to have health related needs of their own, and to need to put their loved one into some type of facility in order to manage their care. So this is a huge opportunity, I think, for Hawaiʻi to really think about from the provider capacity perspective, and how we might augment the number of home health care workers and the home health care workforce. In the cost domain, we saw that there was a rise in preventable hospitalizations. And I can't help but wonder if these two things are tied. You know, lack of a healthcare workforce and more people being admitted to the hospital who are over 65. And this is a measure that is unique to Hawaiʻi, where some other states have been able to make some changes and actually reduce the number of preventable hospitalizations. And this increase in hospitalizations that could be avoided really is something that where interventions can be developed to make sure that there's more prevention that is happening, more teaching for people with chronic conditions, and improved access to community-based services so that people are not choosing the hospital as their point of care. We also saw, we did see a decrease, a slight decrease in the total Medicare spending in the last 2 years of life. And that actually could suggest either more efficient use of resources or people delaying their care. So that's something to also watch. You know, we're starting to see Medicare spending go down for people in their last year of life, but more of them are admitting for preventable hospitalizations. We did not see a change in people reporting through the public health measures that they went without care because of cost in the past year. So in other states, we have seen a decrease in this measure. So fewer people reporting that they're going without care because of cost. And in Hawaiʻi, this is actually staying relatively constant. So no more or fewer people are going without care because of cost. I'm going to stop here and share one other thing before I go back to the presentation. And that is really what the overall scorecard looks like from a domain perspective. And so what you'll see here, I'm going to just zoom in a little bit, are the 4 different domains that I was talking about. So the care domain, communication domain, the cost domain, and the caregiver and community domain. And so these 27 measures are really broken up by domain. And what we developed was a little bit of a scorecard for the state that can help you identify what the differences are between 2020 and 2023. You'll see that very pronounced home health care workers number that was drastically reduced, as well as how that compares to the federal benchmark. So, and that federal benchmark of the United States is compared to the 2023 result. So as you see here in the US, there are many more home health care workers per 1,000 than Hawaii has. However, when you're looking at some of the other care measures, like the satisfaction that people have with hospice, you actually rank on par or higher than the rest of the country related to people's satisfaction when they receive hospice services. So that's sort of how you would look at these results. In the communication domain, what you see here is you're pretty on par with the United States on the patients discharged without instructions for home recovery. And you actually, your scores decreased since 2020. So there are now more people discharged from the hospital without instructions than in 2023 than in 2020. So that's a trend you might want to watch. In terms of looking at the Medicare fee-for-service beneficiaries with advanced care planning, you are much higher than the national average, and that has increased over time. So congratulations, Hope and Jeanette. This is something I would say you have made a direct impact on. So thank you for your work. In looking at the cost domain, what you'll see is in terms of looking at 30-day hospital readmissions, the US is much higher than you. So don't worry, your readmission rate is still relatively low. However, you still have a much higher than the federal average on preventable hospitalizations. So part of this is really making sure that you prevent the first hospitalization rather than just the second one. Some of these measures you'll see are the same number over time. That is because those measures did not change, the data sources did not change. So if you see some of these where co-payments per decedent in the last 2 years of life are exactly the same number, that is because they are exactly the same number. And so it has not been updated since the 2020 release of the data. On the caregiver and community domain, again, in terms of the satisfaction that you're seeing with both home health and hospice care, that satisfaction of services is actually higher than the federal average. So if you look at people willing to recommend hospice, people willing to recommend home health, you're actually quite high. So this is fantastic work. Good job, Dr. Fishberg and Dr. Dolan, for your work here in making it a high quality experience for people who are receiving services. One of the things to note is really around policies supporting working caregivers. And this is a negative trend that we're identifying here. So in terms of looking at the number of policies that public health officials have identified that support family or working caregivers, this is a composite indicator, and it has actually reduced from 2020 to 2023. You are definitely below average on the federal level for adults with food insecurity, and that's, you know, you're almost half the federal food insecurity rate, which is a fantastic thing. So congratulations in terms of looking at and attacking or tackling this measure and making sure that food insecurity needs are being addressed. Some of these measures, as I shared, were re-weighted and changed over time. So if you look at community support, this measure is something that changed. So $608 is not comparable to $54. The calculation for community support dollars related to poverty, that calculation changed in the data. But saying that your funding for community support is currently lower than the federal average. So something to really think about in terms of how to support people who are vulnerable populations financially. Stop sharing here and go back to my slides. So in terms of, I'll send out, we will send out these, that scorecard again, along with these slides. But in terms of looking at how Hawaii like stands up against the other states, this ranking that you're seeing here is out of 51, including Washington, D.C. And what is really driving some of those lower rankings for Hawaii are really around your capacity of the workforce, so the care domain, and some of the changes in policy and services that are available in the community. So not necessarily cost, not necessarily communication, but making sure that you're actually supporting the people with serious illness from the larger community, and that you actually have an available workforce to take care of people at home. Those are two major areas of, you know, opportunity for the state. I already walked through these. So these are really just the numbers, again, that we walked through in the scorecard. The caregiver and community domain, the care domain, where you're seeing this home health care worker challenge playing out. We also see a percentage that is lower than the national average on people saying that they got the help or advice they needed when they contacted their home health provider in their last 2 months of care. And so that's something that has remained stagnant between 2020 and 2023. It's also lower than the federal average of people reporting that they are getting the help they need. So while there is a higher ranking for people's satisfaction, they may not always be getting what they need. And so that's something to really identify. How do we follow up? How do we assess people for their needs? And how do we start to make the right referrals and take action toward their care? In the cost domain, as I shared, a lot of these numbers have stayed the same. So you'll see the asterisks here on a number of measures. This indicates that no updated data was available for 2023. So as I was sharing, the 2020 data are reused for those measures. But of note, as I shared, the 30-day hospital readmission rate has, in fact, been reduced, but only by a smidge. It also is much lower than the national average to start. And when you're looking at people who went without care because of cost in the past year, you are lower than the national average and lower than you were in 2020. So there are more people accessing healthcare and able to have coverage. And the major change that I see that might be needed is around preventable hospitalizations, where there are still some challenges there. This is where prevention comes into play, and helping people understand what they can do at home for self-management. Again, in the communication domain, the major takeaway here is identifying the reason behind why people are being discharged without instructions for home recovery, and to identify areas where there can be more policy around person and family-centered care. So how, if we're really able to tackle food insecurity and lower the rates of food insecurity, how can we improve the caregiver experience in other ways and make it so that people feel like they are supported when they're supporting others? Some of the things that we have done with other states as C-TAC in using or interpreting the ACT Index report are in supporting states to develop policies and benefits that support or improve these scores. You also are able to really use these scores to mobilize around workforce capacity and workforce development, whether that be training and competencies, or it's about new pipeline programs for home health aides, or working with the schools, like I know you have a long history of doing. In the communication domain, this is really a way to celebrate your wins in being able to demonstrate that you are increasing the advanced care planning rate over time in your state, and how actionable that is, how you're actually able to see that improvement year over year. On the community side, these are really about addressing basic needs and in helping people understand how to navigate the system or how to get resources. And so it might be something to really think about as a group to identify areas where you can help people be more aware of the services available, or to identify areas where you can address people's basic needs, whether that's caregiver support or respite care or more community training or case management type services. I think we have some time for questions.
Great. Well, thank you so much. People can put their questions in the chat. If you'd like to, you can also raise your hand and we could call on you. And in fact, Dr. Fishberg has raised his hand. So there we go. Let's start with him. Daniel, can you mute yourself and ask the question?
Can you hear me now, Jeanette?
Yeah, we can hear you.
Okay. I think I've got the Zoom thing down now. Torrie, thank you so much. That was just a fire hose of information, but all fascinating. Really, really appreciate it. The big challenge for me now is to try to read this chicken scratch of all these notes I took. But one of the things that jumped out to me is that the preventable hospitalizations. If I saw it right, it looked like we made meaningful improvement there, and yet are still significantly below U.S. mean. And I was thinking, gosh, I think we've made some good progress here with our community-based palliative care, which if I'm looking to attribute that, first I'm thinking, well, why are we better? And then why are we not good enough yet? And so that was the first thing that came to my mind. But then I'm trying to think, well, I kind of think we are a little ahead in terms of that community-based palliative care. So why are we so behind? Do you have any theories about that? Why Hawaii is lagging still, despite improvement in preventable hospitalizations?
Yeah, I appreciate that question. I think, and there was a question also to me in the chat related to what is the definition of a potentially preventable hospitalization. So I'm just going to put this in the chat so that everybody can, it can be for posterity. This comes from the Agency for Healthcare Research and Quality. And a potentially preventable hospitalization is an inpatient stay that treats ambulatory care sensitive conditions that evidence suggests may be avoidable, in part through timely and quality primary and preventive care. And so, in terms of being able to make real inroads related to community-based palliative care, I think that's fantastic. I think the additional piece is really around your public health type measures around diabetes prevention and asthma control and other things that may be even environmentally related in the state. Those are things that help to prevent a serious illness from occurring and are much, much farther upstream. Right. So these hospital admission rates are then conditions that can be managed through upstream education.
Okay. So that's really helpful that you clarified with that definition, Torrie. So if somebody has stage 4 cancer and is admitted for uncontrolled pain, that might, even though we might think that's something maybe that community-based palliative care could help with, that might not meet the numerator for this, because you say, hey, the patient's got stage 4 cancer. It's quite understandable that they might have pain that needs more. Okay.
Yeah, these are really ambulatory sensitive conditions. And a lot of this is things that are, so if you're thinking about chronic conditions, it is how well are we able to manage somebody at that certain stage so that they are then not moving to another stage as quickly. So identifying or early screening of CKD, for example, right? Chronic kidney disease, making sure that people don't get to end stage renal disease as quickly, and preventing potentially avoidable hospitalizations as related to something like that. And really something that I have seen in sort of my public health days is really around stroke prevention, right? Making sure that people have a better diet, better managed and well-controlled symptoms, hypertension is managed, that people are actually adhering to their diabetes, insulin, medication, etc., so that stroke is prevented in the hospital. And that's something to really watch.
Jeanette, I do have other questions, but I wanted to give other people a chance.
Joyce had a question we'll get to in a minute. Susan Christensen said this is exactly it. Patients can't get timely appointments with the PCP for 6 months, which we all hear that there's such a long waiting list. One question that I had, Torrie, what is the impact of the fact that so many people in Hawaii have Medicare Advantage? Like, we watch that with the ACP thing, so that Medicare Advantage isn't in that. That's the fee for service. Does that impact also the home health numbers at all? Can you talk to that a little bit?
It doesn't necessarily impact the home health numbers. Those are actually reports by people by age band. And so it's not specific to somebody being Medicare fee for service. I also saw a question that was related to these age bands, so I wanted to address that too. In public health, they have different age bands than the age bands that CMS uses. And so when you're looking at America's health rankings or the BRFIS measures, et cetera, those actually go by, people over 75, people 65 to 75, people 55 to 65, right? And so some of the things that we're really looking at in terms of people's level of function or their level of need is that you have more need when you're over 75. But we can definitely drill down into, say, that lower level of age band. I do think some of the impacts of some of these numbers are really where you get the data. But when you're looking at the public health measures, those are everybody in the state, right? That are getting the same survey, that are responding to the same phone calls. And so those measures are not sensitive to, administrative claims. I do think that if you looked at the Medicaid claims numbers specifically, you may get a different story. And if you actually look at the insurance companies and their claims, you might get a different story for some of those things that really rely on the fee-for-service data.
So many questions. Excellent. Thank you, Torrie. Joyce had a question about food insecurity and the Maui fires. Is that in the data yet? If it was last August? Not yet, right?
Not yet. That would show up in next year's.
Okay, good. Well, Dr. Fishberg had some more questions. I don't see anybody else with their hand up, so go ahead, Daniel.
Well, thank you, Torrie, for pointing out that pretty frightening drop in home health care workers for seniors, down by 80%. Just the first question was, how is that actually measured? And any thoughts on what's that all about? Because that does sound rather frightening.
I'll have to pull this up in terms of how it's actually measured. This is a measure by the population. So in terms of looking at how many home health care workers are available by 1,000 people, right? So it's sort of looking at, does the number of home health care workers keep pace with the people in that age band, right? People over 65. And so, if you have more people over 65, and even if you're keeping the same number, you're going to decrease the number of available home health care workers. So that's sort of how that's calculated. And this is a trend across the country, definitely a problem. And so, I think what's all that about is a really good question. The first, and we actually looked at this 4 or 5 times just to make sure the numbers were correct, because it was so startling. The interesting thing about that is what we saw were a lot of people exiting the workforce. So that's the first thing. A lot of home health care workers exiting the workforce. To your question, Joyce, also included people who did not renew their license. So people who were licensed home health care workers, that number went down. So they actually were not able to be used by certified facilities or as certified home health aides. And so that actually poses a problem for hospice programs, for palliative care programs, where on your plan of care, you actually might need a certified home health aide or to use a certified agency. And now you just don't have people. At the same time, we are seeing a lot more people starting to purchase direct care workers off of the private market rather than going through somebody that is licensed. And so this is a trend to really watch, because that means people are paying out of pocket for direct services rather than going through an agency that can oversee and monitor quality and compliance. And in addition to that, I think the major impact, Daniel, is on the wages. Is that you can actually get paid more as a home health aide on the private market than you can through Medicare reimbursement. And so this actually is something to advocate for, is how do we actually increase the wage index for people who are home health aides, people who are home health workers, so that they are incentivized to actually be part of the healthcare delivery system rather than to go out on their own, because that has real impact on quality of care. It makes it really tough for hospice programs and other, home health programs to be able to really access these providers.
Yeah, that's eye-opening. I know we only have a couple of minutes left, but Torrie, sort of looking at that first figure you showed us, it showed Hawaii sort of in the middle and a whole bunch of sort of mountain states over there on the left, and some maybe more mixed industrial rural states over on the right. Any patterns jumping out? Does it correlate to state spend? That was not going to be my guess. Does it?
It correlates to state spend specifically in community benefit dollars. And so these are, a lot of them are rural communities that are have a long history of taking care of their own, who during the pandemic invested in community benefits, in caregiver supports and services, who invested in home delivered meals, who invested in a lot of those community components to really shore up the infrastructure in their state. And so these states really jumped to the top. You know, you're seeing Wyoming, Utah, et cetera. And at the same time, many states that have more suburban or urban areas really were on the lower side because they could not keep up with costs and capacity in their state. And so, you know, in order to really move the needle across all domains, there does need to be some mix of public and private interventions. And there needs to be some mix of community-based organization infrastructure and healthcare workforce improvements. And so, you know, that mixture is a really hard thing to get right. And what I have seen is that states really choose one domain and go after it. And so what we're going to be spending the time doing in the next iteration of the index is actually to start to give some weighting to these domains to really support, support making sure that, you know, folks who are actually getting higher ranks are not just because, you know, you're gaming the system in developing community benefits. It's a great question.
Yeah, absolutely. Well, I know that some people have to leave because it's 1 o'clock, but Torrie has said that she will stick around and continue to talk data and strategize with us. We recognize some people may need to leave. And, you know, as you were talking, Torrie, for me, the question, of course, is, so what are the most important pieces that we should be working on? So just want to make sure that you see everybody is thanking you very much for your presentation. And again, we can, if you have the time, I'm really interested, especially when we look at things like caregiver support keeps coming up, and the idea of public-private, what sort of initiatives are possible.
Yeah, you know, I think the pretty significant trend that I see, you know, the data tell a story in some ways, where there is, in order to really help people feel like they are getting the right discharge instructions, and in order to be able to help people feel like they are getting their needs met by their care providers, there does need to be some availability of a workforce to sort of help with care navigation and care coordination and training and teaching for people and their families. And, you know, if you look at the impact of on the workforce in Hawaii, you know, you're in a space that's very far away. It's not like people can drive into the state and provide more services, right? And so, you know, in thinking about that, I think there is an intentional shift that needs to happen in helping to connect people with community resources, to help with care navigation, to help with aid and support for people who are receiving discharge instructions, and to also help people really understand new diagnosis even earlier on in the process than when it becomes a serious illness. And a lot of those things are really public health, classic public health preventive measures, as well as things that are not high cost, but they do take workforce, and they do take training to do care navigation and care coordination and home aid services, et cetera. And so, I think it's a question for me about, what can be done in Hawaii to really support the pipeline, the workforce or healthcare workforce pipeline earlier on for students, for young people who could qualify to provide these services. And how can you get more people into lower level nursing type jobs like certified nursing assisting programs or things like that, that may actually really help alleviate some of these challenges.
Yeah, and fortunately in Hawaii, there are quite a number of initiatives. It's not like none of us have heard this before, although that home health piece is very disturbing. So there are a number of things happening. For instance, we have this thing with high schools called health academies. Dr. Morita is involved with that. Can we help, train CNAs and EMTs early? There's a number of initiatives like that. So that's good. We also, in the state, there's a lot of CHW, community health worker movement, if you will. And we have amazing people. And we from the Kokua side are really excited about that, because a lot of times that also can help with that cultural interpretation as well to help people. So as I'm thinking about what are we doing and what can we be building on, okay, let's keep on with our community health worker activity and keep working there, because that's really important. Thinking about the training. And what are we going to do about the high cost of housing? Right. Housing is such a health issue, and we can't get away from it. So you're right. Nobody's driving here from anywhere else. We're all now just living 14 to an apartment, trying to figure this out. So there's other things too that are so important. I'm interested too in policy around caregiver support. That's another thing in case you have any ideas.
One of the growing trends to help offset the workforce and to help support caregivers is actually in direct reimbursement to caregivers who receive training. And this is something that a number of states actually applied their ARPA funding, their American Rescue Plan Act dollars toward in being able to create stipends for consumer-directed care or for family caregivers. And one really great example is in the state of New York, where they have this consumer-directed program. And that program actually trains people to be caregivers. You're enrolled in a program that supports caregivers, and then you're paid to be a caregiver. And that allows the caregiver to understand how to navigate healthcare on behalf of someone else. And it doesn't necessarily have to be a family member, but you have to receive that training. And I do think that that's something where, especially with the workforce shortage challenges that we're seeing across the country, that's something to really think about. And if you have 6 people to a home, or 12 people to a home, which you see sometimes in Hawaii, how can you help to support, the household by being a paid caregiver? So it also sort of directly impacts wages.
We've had a program here for quite a while. It's just, in my mind, tremendously underfunded. So there's a very few number of family caregivers that actually get paid. And so there's an idea. Let's increase the funding for kupuna care and like those kinds of things. I think that's really important.
Yeah, the other thing that I have seen be increased in a number of health systems is actually proper documentation of caregivers. So presence or absence of a caregiver, and documenting that as a standard part of the healthcare record so that we have a better understanding of who actually has one or who doesn't when they're coming to the doctor. And that can help providers actually intervene earlier when they know that somebody has no known caregiver on file, right? And then when something occurs, when there's a healthcare challenge, you would treat that person differently, knowing that they don't have a caregiver in the home, knowing that if you're discharging them into the community with no one to help them, that maybe they will come back to the hospital. And actually documenting that is just the first step. And we're also seeing in the electronic health record is already something called the ZERIT, Caregiver Burden Inventory. And that's something that is being regularly used in palliative care services or in hospice even, but it is in your standard health system health record. And so actually sort of requiring that a caregiver burden assessment be performed for people goes a long way in then being able to address caregiver burdens.
And so most the main health systems here have Epic, and then Adventist has Cerner. Not sure about HHSC, but are those two, they would have that? And how are you spelling ZERIT?
ZARIT, ZERIT.
Okay.
And that, the ZERIT assessments are standard in Epic and in Cerner. It does mean that there would need to be a requirement to complete it. And so that's why a lot of people don't use it, because it's there. It's just not required. And so, I'm not saying that everybody necessarily needs that, but especially when you have specialists or you have people who are in the hospital, those are things that are really important to really help support.
Right.
I see in the chat there's the CMS new reimbursement for social determinants of health and those assessment visits for providers. And I'm a huge advocate for the community health integration reimbursement that is happening, which is for health-related social needs and screenings for that. The SDOH assessments not only pay for screenings for health-related social needs, but also pays for follow-ups to those screenings to ensure that gaps are closed. And I do think that is something that is a really supportive thing that can help to offset some of the burden on caregivers who need to think about caring for their loved one and cooking dinner. Or paying their bills.
Does anyone know how widespread that is in Hawaii? Are people doing that? Sometimes it takes, like you were saying, with codes or it takes a while for people to recognize that it's out there. But in case people know, let me know, because that seems like another thing to help people, important to understand about. Again, caregiver burden is so important. Great.
One thing, Jeanette, your areas on aging may definitely know about how widespread that is. There has been a pretty broad effort that's been funded by the Robert Wood Johnson Foundation to help support areas on aging in understanding how to help the healthcare delivery system implement those codes.
Oh, that's great. Well, we began in the Office on Aging and have collaborated with the AAAs, and since that time, there's always more to do, but that's great. They are such a great resource in our community. So that's important. I will follow up with that. That's really great. In case people want to keep talking about this issue, I think that there's so much to be, there's a lot of data, but also this question of what to do next. And, for me here, like, okay, what are the policies? What could we be looking at? I always like seeing what other states have done, whether it works or it doesn't work, and kind of build off of that. So if anyone else is interested, let me know.
Well, thank you so much for having me. And I love spending time with Kokua Mau, so I'll come back anytime.
Thank you very much. Thank you, Torrie. Thanks everyone for coming, and hopefully we can keep on talking. So thanks everybody.